We are live. Oh, she's already here. Admit. Hello, Doc.
Hi, good evening.
Good evening, Doc.
How are you?
I'm fine. How are you?
I'm okay. So we are waiting for your colleagues.
Yeah, we have 3 so far. 4, okay. Yeah, found it. There we go. Actually, today you are here.
I'm just hoping that the network will not worry me again.
Yeah, me too. Because it's
Okay.
I think we can maybe
Start.
yeah, we can start.
Let me share the slide and
Okay.
oh sorry. Let me I thought I opened so today we are going to talk about pediatric diseases. Okay. So we are talking about pediatric diseases today. So this is the outline. We'll look at congenital anomalies, infections in children, prematurity, intrauterine growth restriction, respiratory distress syndrome, necrotizing enterocolitis, sudden infant death syndrome, and Hydrops Fetalis. So when we talk about congenital anomalies, we mean structural defects that are present at birth. Sometimes the defects are there, but it may not be clinically apparent until years later. So for example, a baby who has a heart defect, you may not see it. It's not visible on the body, it's within. But once it's a physical defect, it is a congenital anomaly. So maybe years later, you'd realize that maybe the baby has heart failure, you investigate, and then you find out. Okay. So there are several types of malformations. You have severe ones and then not so severe ones. So the first diagram is, the first picture is a baby with polydactyly and syndactyly. So syndactyly is fusion of the limbs, and polydactyly is more than the required number of fingers. So if you count, you realize that this baby has 6 fingers and 2 of them are fused. The thumb is, they are fused together. Then we also have amniotic band constricting the fingers and causing something like a fracture or a band around the finger. Then we have cleft lip. And then this is a baby with anencephaly, no cerebrum. So the front of the brain didn't form. So you just have the brain stem. These pictures were taken in Kolebu. This is a baby with an omphalocele. That is herniation of part of the intestine and the liver through the umbilical cord. Okay, so what's the etiology of these congenital anomalies? So usually two main categories, either genetic or environmental. So genetic means that it is inborn from genetic mutation. So either there's a problem with the chromosome, so chromosomal aberrations, or it is inherited by Mendelian inheritance. So you have autosomal recessive, autosomal dominant, and so on. Then it can be multifactorial. So, for example, babies with hydrocephalus, very big head, full of fluid. It can be multifactorial because you can have genetic issues affecting it in the etiology. Then it can also be due to lack of folic acid during the pregnancy. So that's what makes it multifactorial. Now, the environmental factors are plenty. Infections during pregnancy, diseases of the mother, which affect the fetus because they cross the placenta, they cause chemicals or things to cross the placenta, or medications that the mother might have taken during the pregnancy. Typical amongst them is alcohol. And usually what happens is that these things occur, the damage occurs very early in the pregnancy, a time during which most women may not even know that they are pregnant. Like 3 weeks, 2 weeks, thereabouts. If a woman abuses alcohol, she may not know that she's pregnant, so she shouldn't drink during the pregnancy. And by the time she realizes if she's an abuser, she might already have taken quite a substantial amount that can cause infections. That can cause congenital anomalies, sorry, not infections. So we move to perinatal infections. So perinatal infections are infections of the fetus and neonates, which occur either whilst in utero, in the womb, or just around the time of delivery. So these infections can be acquired either transcervically or transplacentally. Transcervically is also an ascending infection, and transplacentally is hematologic. So if it is transcervical, it means it is an ascending infection from the cervix. So it gets to the cervix and then gets into the uterus, affects the amnion and the membranes, and then enters and affects the baby. So this can be acquired either whilst in the womb or during the birth process. Okay, and a lot of bacterial infections are acquired this way. So usually the fetus can acquire the infection by inhaling infected amniotic fluid or swallowing infected amniotic fluid. And this inhalation can cause pneumonia. And in severe cases, you can have severe sepsis, you can have meningitis as a result of this. Now, the transplacental infections are usually carried through the blood from the placenta to the fetus. And examples are the TORCHES. So TORCH is an acronym that stands for toxoplasmosis. Others, so for the others, we have Treponema pallidum, which causes syphilis. Then the C's, then R is for rubella, C for cytomegalovirus, and then H stands for herpes, and then HIV. So all these infections can be transmitted transplacentally to the fetus. So fetal infection can cause so many clinical features. You can have fever, you can have encephalitis, you can have an enlarged spleen and liver, pneumonia, and so on. Okay, so we move to prematurity. Prematurity means that a baby who is born before their time. And this is defined by delivery at a gestational age less than 37 weeks. So once the pregnancy gets to 37 weeks, that baby is not preterm technically. sorry, please give me a minute. Ophelia, is a baby who is born before 37 completed weeks. You can also have a baby who is small for gestational age or low birth weight. So low birth weight means less than 2,500 grams. So those two definitions are different, but they can overlap. So premature babies are usually small, and so they can have a small weight. But sometimes the preterm baby can also be big. So we don't always use the weight to determine whether they are premature or not. But the peculiar thing about premature infants is that their organ systems are immature, and that makes them vulnerable to several complications. So what are some of the causes of prematurity? You can have premature rupture of the membranes around the baby. You can have infection of the membrane, so that's called chorioamnionitis. You can have abnormalities with the placenta, which will cause the woman to go into premature labor, or twin pregnancy. The ideology behind twin pregnancy causing prematurity is that because there are several babies, they cause uterine crowding, and then the uterus becomes bigger than if it were carrying just one, and that would stretch the muscle and cause contractions to occur. So these are some of the complications of prematurity. You can have highly membrane disease, which is also known as respiratory distress syndrome. Then you can have necrotizing enterocolitis. We'll look at the first two into more detail. Now, the intraventricular hemorrhage usually occurs when there's bleeding into the brain because the brain structures and the blood vessels are fragile. So let's look at intrauterine growth restriction, commonly called IUGR. So a baby with intrauterine growth restriction is born at 10. That baby is not premature. They are born at 10. But what has happened is that their weight is less than 2,500 grams. So they are born at their normal time, but their weight is less than the average for a baby who is born at 10. And several causes exist. We've divided the causes into fetal causes and then maternal causes and placental causes. So some of the fetal causes are infections of the baby, chromosomal disorders, and so on. So with the fetal causes, the growth of the baby is symmetrical. The IUGR is symmetrical. What this means is that the head is small, the body is small, and the weight is small. So that's a symmetrical IUGR. Usually, the maternal causes would give you asymmetrical IUGR. So what that means is that the head is big, but the rest of the body is small. And usually this occurs because this abuse or this problem occurs later in the pregnancy. So by that time, the head has already developed and it has attained its size. And then the rest is for the rest of the body to grow. And so at the time that this occurs, the head is already okay. So the head size is bigger compared to the body. So the placental causes are anything that compromises the supply of blood from the uterus and placenta to the baby. So we have things like placenta previa, abruption, infarction, and so on. Then you can also have maternal causes. So for the maternal causes, you have things like preeclampsia, that is high blood pressure during pregnancy, chronic hypertension, alcoholism, cigarette smoking, and narcotic abuse. So what are some of the complications? They can cause cerebral dysfunction, learning disabilities, sensory impairment. So this can be visual or hearing. So the next thing we'll look at is respiratory distress syndrome. So respiratory distress syndrome is a condition where a newborn is born and they have respiratory distress, simply put. And the causes of respiratory distress can include excessive sedation of the mother. So when the mother is heavily sedated with, let's say, painkillers during delivery, the baby comes out and the baby is sort of intoxicated with the narcotics or the sedation, and so the baby has difficulty breathing because the narcotics can depress the respiratory center in the brain. Then if the baby aspirates or inhales some of the amniotic fluid, it can cause congestion in the lungs and interfere with the breathing. Then things like cord around the neck, which can compress the fetal neck and lead to hypoxia, can also cause respiratory distress syndrome. But the commonest cause of respiratory distress syndrome is prematurity. So what happens is that usually this is common between 32 and 36 weeks of pregnancy. And the more premature the baby is, the worse the respiratory distress syndrome. Other things that can contribute to respiratory distress apart from prematurity are maternal diabetes, and then cesarean section before the onset of labor, and then twin gestation. It's been noticed that males are at greater risk of death compared to females when it comes to respiratory distress syndrome. Now, the main issue with respiratory distress is the inability of the immature lung to synthesize a chemical that we call surfactant. The surfactant is a complex chemical which has phospholipids, and principally it is synthesized by cells in the lungs called type 2 pneumocytes. These cells start producing the surfactant in the latter part of the pregnancy, the third trimester. So if a baby is born too early, that baby will not have the opportunity to have this surfactant produced. Now, what does the surfactant even do? The surfactant coats the surface of the alveoli and helps the alveoli to remain open, or it helps the alveoli to expand by reducing the surface tension. So if the alveoli is not able to expand, it means it will collapse, and so the baby will not be able to breathe well. So basically, that's all that happens. If the alveoli collapse, it means that you need a lot of force, excessive force, to keep it open. And that is why the babies have respiratory distress, because they cannot generate that force to open the alveoli. So you realize that a lot of the alveoli have collapsed. Now, there are some hormones that affect surfactant synthesis. So examples are corticosteroids. So if you've had somebody who delivered premature, the obstetrician will tell you that, oh, they have to inject steroids into the mother so that the corticosteroids will stimulate the formation of surfactant so that it will develop the lungs such that the baby can breathe better. Thyroxine also acts like the corticosteroid, so it's synergistic. However, insulin antagonizes this effect. So if you have a pregnant woman who has very high sugars and therefore produces a lot of, has to be injected with a lot of insulin, that insulin can go and antagonize the effects of the surfactant and depress the respiratory, the synthesis of the surfactant, and further depress the respiration. So infants who are born to diabetic mothers, because of the problem with their glucose control and insulin injection, you can have that problem as well. Then also labor is known to increase the production of surfactant, because obviously if the woman goes into labor, it's a signal that the baby is about to come out. And so the lungs will have to quickly start producing the surfactant so that the lungs can be mature before the baby is born. So if you have a situation whereby the woman undergoes cesarean section or doesn't go into labor, it means that if the baby is premature, then the lungs will not be well developed because the surfactant production will not happen. Okay, so morphologically, if you look at an infant with respiratory distress syndrome, you realize that the size of the lungs are normal, but they are heavy because a lot of the alveoli have collapsed, so they are clamped together. And then they look purple in color, and you see that there's a lot of poorly developed alveoli. If the infant dies within the first few hours, you see necrotic segments also. Yeah. So if you stay in it, you will see a lot of eosinophilic hyaline, and that is what gives it the name of hyaline membrane disease. So if you look at this slide, you see some pink and then some blue. The pink is outlining the eosinophilia, which occurs in the collapsed alveoli. And you see that there are some dense areas alternating with open up areas. So the eosinophilic areas are lining the alveoli. So the pink large areas are alveoli lined with hyaline membrane. Then the surrounding areas also have collapsed alveoli. So clinically at birth, the infants may appear normal. Then within a few minutes after they are born, they start to have this difficulty breathing, which worsens progressively and then gets better. And that can cause death in the neonatal period. Sometimes the respiratory distress can be so bad that they need to be put on ventilators to support their respiration. So, like I said, ventilation is what helps. Sometimes you can give surfactants. You can pass an endotracheal tube into the trachea and then inject the alveoli, which goes into the lungs and helps with the development. However, the ventilation is just to give support. The less the gestational age of the baby, the more likely that the baby might die. So maybe if you have a 28-weeker compared to a 32-weeker, the 28-weeker has a higher chance of dying compared to the baby who was born at 32 weeks. Okay. So they also have a lot of complications in the long term. So they have things like chronic lung disease, and they can also have neurological abnormalities because they are starved of oxygen for a long period. So the long period of hypoxia can cause brain injury. Then sometimes the ventilation too, if the pressure of the oxygen being given is high, it can cause lung injury as well. So this can be prevented by basically preventing premature delivery, because we know that premature babies who are at risk of respiratory distress. Okay, then you can also prevent it by giving corticosteroids. If you know that this woman is at risk of preterm delivery, then you give steroids to mature the lungs. Okay, so we move on to necrotizing enterocolitis. This is a complication that basically affects premature babies, and it is associated with intestinal ischemia. Now, what happens is that there's reduction of blood circulation to the intestine, and this usually occurs when there is reduction of blood flow generally. So when the blood flow generally decreases, what happens is that there is shunting of blood to the vital areas, the brain and the heart. So the other parts of the body will get very little blood supply. So this can occur in infants who have hypoxia. For example, if they have a hypoxic injury, maybe there's cord around the neck such that there isn't enough oxygen. Once there isn't enough blood, there isn't enough oxygen in the blood, the body will try and preserve that small blood to vital organs, the brain and the heart. So the other parts of the body will not get much blood. So this ischemia, this poor blood circulation to the intestine will cause ischemia. So there will be ischemia of the gut, of the intestine. Now, if you go ahead and you feed these babies, especially with formula feed, then you end up worsening their situation, because they have ischemia and they are supposed to, the gut is sort of dying. And then when you bring the feeds, they are not able to digest and absorb the feed. And so bacteria will act on it in the gut. And this bacteria will also move into the blood supply because the gut has undergone necrosis. So this would lead to injury to the gut. And this typically involves the terminal ileum, the cecum, and the right side of the colon. I'm sure these are all terms you are familiar with in anatomy. So the intestine will become very friable. It will become distended, and then there'll be congestion. If it is so thin and friable, it can perforate, and then you end up with peritonitis. So if you look at it under the microscope, you realize that there's submucosal gas bubbles. There's gas under the intestine wall. Then there's ulceration and bacteria there. And then you can also have necrosis. Okay. So this is a diagram showing, this is a picture of gut which has undergone necrotizing enterocolitis. So you see that it looks like it's ballooned out, it's been blown up, and it's very distended, and the wall becomes very thin so that it can easily perforate and cause peritonitis. So usually clinically, the baby starts with bloated abdomen. Usually this occurs after formula feeding for the preterm babies, and premature babies are more at risk of this. There's abdominal distension, then they pass bloody stools. Then you realize that there's circulatory collapse, so they can go into shock. And when you do the X-ray of the abdomen, you see that there's gas within the walls of the intestine, what we call pneumatosis intestinalis. If you see it early, all you do is conservative management. You stop feeding, you pass an NG tube to decompress the gut, and then you rest the gut. Hopefully, the infant will survive. But sometimes when there's perforation and peritonitis, you have to go in and do surgery, cut out the areas of the gut which have become necrotic, and then resuture the ends together. So the next thing we look at is sudden infant death syndrome. So this is a child less than 1 year whose death is unexplained after the performance of a complete autopsy, examination of the scene of death, and then review of the history and physical examination findings. Usually occurs in infants below 6 months of age, but most of them is between 2 and 4 months of age. And usually the death occurs during sleep. And excuse me, sorry. The cause of sudden infant death syndrome is unknown, but there are lots of risk factors which are associated with this. And the commonest thing is putting an infant to sleep in the prone position. You know, the prone position, lying with the head on the bed. That is associated with sudden infant death syndrome. There are other factors associated with it: prematurity, low birth weight, male sex, multiple births, so twins or triplets, then a history of sudden infant death in a prior sibling. For the maternal factors, you realize that these all have to do with low socioeconomic status. Okay. So morphologically, when they did an autopsy of these babies, some of the things they found were petechiae or bleeding on the thymus, then congestion in the lungs, and then changes in the brain. But it was realized that none of these changes could adequately explain what was happening. Sorry, so let me say a little more about this sudden infant death syndrome. So it's been realized that usually what happens is that when the baby is asleep and put on the head in the prone position, what happens, because they are infants, they are not able to turn when they are suffocating. They lie down and they suffocate, and that can cause the death. And usually this occurs during sleep. So there's a new recommendation of putting the babies with their back to sleep. So the best position for a baby is either you put them on their back or on their side so that you can avoid suffocation. Then we have Hydrops Fetalis. So Hydrops Fetalis is a term used for generalized edema of the fetus and usually occurs as a result of fluid accumulation whilst in utero. And there are several things that can cause this. So it can be from chromosomal anomalies. So babies with Turner syndrome or trisomy 21, 13, 18. So trisomy means you have 3 copies of that particular chromosome. So trisomy 21 means you have 3 copies of chromosome 21. Trisomy 13 means you have 3 copies of chromosome 13 and so on. Or it can be caused by fetal anemia. It can also be caused by cardiac anomaly and then twin pregnancy, whereby you have a twin-to-twin transfusion syndrome. So one twin gets a lot of blood at the expense of the other twin. So these are pictures, postmortem pictures of fetuses with Hydrops Fetalis. So this is generalized, and this is a baby with the fluid accumulation just around the neck. Okay, so we'll look specifically at what we call immune Hydrops Fetalis. So immune Hydrops Fetalis results from an antibody-antigen reaction between the red blood cells of the baby and then the serum of the mother. So that is what we also call incompatibility. Commonly, it results from rhesus and then ABO blood group antigens. I hope you are familiar with the blood groups.
No.
Okay. So we have ABO blood group system, whereby we have blood group A, blood group B, blood group AB, and blood group O. Then we also have the rhesus system, which is rhesus positive and rhesus negative. So the two combined will give you maybe blood group A positive or negative, blood group B positive or negative, blood group AB positive or negative, and blood group O positive or negative. So there can be incompatibility between the mother's blood group and the baby's blood. The mother's antibodies can cross the placenta into the baby and cause and attack the baby's red blood cells. So when they attack the baby's red blood cells, they will cause hemolysis, and this will lead to anemia. Then this fetal anemia would lead to tissue ischemia, it would lead to cardiac failure, and will lead to pooling of fluid or edema in the fetus, and that is what will cause the Hydrops Fetalis. So let's try and understand the rhesus isoimmunization, which is a type of incompatibility. So usually what happens is that if the mother is rhesus negative and she marries or she conceives with a man who has rhesus positive blood, what happens is that if there is some mixture of blood between her blood and the baby's blood, let's say during delivery, there's a lot of bleeding during delivery. So maybe some of the fetal blood gets into the mother's circulation. That positive blood that has entered her circulation will cause her negative blood to start producing antibodies. So usually the first pregnancy, nothing happens because during the pregnancy, there's no mixing of blood between the mother and the fetus. It only occurs either during delivery or if she gets an abortion or there's a termination of that pregnancy. But during delivery, once you have just about 1 ml of the rhesus positive red blood cells getting into the mother's circulation, it stimulates her immune system to produce antibodies against this blood. If the obstetrician doesn't take note of the difference in the blood group and the woman will deliver normally, there will be no problem. But if nothing is done, these antibodies which have been produced will stay in the mother's blood. if she gets pregnant the second time and the second baby has positive blood group, then the antibodies that have been produced in her blood following the first pregnancy, yeah, a few minutes left. Following the first pregnancy will cross the placenta and attack the fetal red blood cells. So for rhesus isoimmunization, it usually spares the first pregnancy. The first pregnancy is safe. So usually if your blood group is negative, the obstetrician will give you an injection called anti-D. This anti-D will get into your blood and mop up or react with all the antigens that have antibodies that have been formed in your blood, so that you don't have any antibodies to attack the subsequent baby. If this is not done, then the next baby is at risk of having this rhesus isoimmunization, and the mother's blood group, mother's red blood cells, the antibodies can attack the baby and cause breakdown of the baby's red blood cells, leading to severe anemia in the baby. And then the breakdown of the red blood cells will also cause accumulation of bilirubin. So there will be jaundice. So these are the babies who are born and then they have jaundice. Okay. So another incompatibility can occur with the red blood cells. So for ABO incompatibility, it means that the mother's blood group is also incompatible with the baby's blood group. But this is not rhesus. This is the A, B, and the O. So basically, blood group O has both antibodies A and B in the blood. Blood group A has antibody B. Blood group B has antibody A. And blood group AB has no antibodies in the blood. So if the mother has blood group O, she has both anti-A and anti-B antibody, which can cross the placenta. If the baby is, let's say, A, they will cross the placenta and then the anti-A would react with the baby's blood and cause breakdown of the baby's red blood cells, leading to jaundice. Now, this ABO incompatibility affects about 20 to 25% of pregnancies. And usually, it doesn't spare the first pregnancy because the blood group is something that we have from birth. So this one doesn't spare the first pregnancy. It is different from the rhesus. For the rhesus, when the positive blood enters the mother, it is now going to cause the stimulation of antibodies. But for ABO, the mother already has the antibodies. So they'll just cause the placenta and go and cause the havoc. Okay, so the firstborn may be affected as is stated here. Okay, so usually there'll be anemia. We have less than 1 minute. Okay.
Yeah.
So usually there'll be anemia, and this anemia will lead to circulatory failure. It can cause liver failure and then can cause edema. The liver failure is what would lead to decreased level of albumin in the blood, which will cause the edema. And then the heart failure can also contribute to the edema. So morphologically, they look edematous, basically, and they can be stillborn, and you can have problems with their circulation and